Chapter 6. Doctors and Patterns. From Warner Slack, Harvard Medical School. If a physician can be replaced by a computer, then he or she deserves to be replaced by a computer. From Vinod Khosla. It's sort of criminal to have radiologists doing this, because in the process, they're killing people. Several years ago, after a horrific bout of abdominal and back pain, I was diagnosed with stones in my left kidney and ureter. 2 stones were in the ureter, and they were pretty large, more than 9 millimeters. I was unable to pass them, despite drinking gallons of water and taking drugs like Flomax to increase the chances. The next step was a lithotripsy, a procedure that applies high-energy sound waves from a lithotripter machine outside the body to the ureter region to break up the stones. The procedure is quite painful, although why it is so is poorly understood, and often general anesthesia is used, as it was in my case. A week after getting the shock waves, I was hopeful for evidence that the stones had broken up, or had even disappeared. A simple KUB, kidney, ureter, bladder X-ray, took just a couple of minutes. The technician who took the picture reviewed it to be sure it was of adequate quality. I asked her whether she could see the stones in my left ureter, and she wasn't sure. In looking at the film myself, I wasn't sure either, so I asked to speak to the radiologist. That doesn't happen very often. Unless the radiologist is interventional, which means a specialist who does treatment procedures, like placing a device in a blood vessel, radiologists rarely have contact with patients, whether to discuss the results of a scan or anything else. The normal operating procedure is that the radiologist, who sits all day in a dark room looking at films, makes the interpretation and files a report. Most physicians never look at the X-rays they order, but just the report to review the results with the patient. It seems a bit like going to buy a car. You talk to the salesperson, but never meet the dealer. When you're negotiating with the salesperson, he or she goes to another room to check with the manager. If you've had medical scans done, you've likely never met the reader of the scan, just the photographer. Oftentimes, however, the photographer meets with the reader, either personally or digitally, while you are sitting there to make sure that the scan is technically adequate before you can get dressed and move on. After sitting in the waiting area for 15 minutes, I was taken back to the dark room to see the radiologist. Via the reflection of the screen, I saw a dark-haired, bearded, prophet-looking white guy, about my age, who was affable and seemed quite pleased to have me visit. He pulled over a chair to have me sit next to him. I was wondering why he was wearing a long white coat, and thought he might as well be in jeans and casual clothes, or even pajamas. The radiologist digitally pulled up my many kidney-related scans at once on a large screen to do side-by-side comparisons. The CT scan that had led to the original diagnosis a few months back showed the 2 stones really well, so that scan was the comparison for the new KUB study. The radiologist magnified the new film many-fold to zoom in on the stones. To my chagrin, not only were the stones still there, but they hadn't changed in size. Only one had migrated downstream a bit. The treatment had resulted in a trivial change. My kidney was still dilated, so there was some obstruction, which raised our concern about how long that could go on without some permanent damage. Despite all the bad news, I got a lot of insights into my condition from this session, much more than I would have gotten from a review session with my urologist. From the radiologist's perspective, the lithotripsy procedure was likely a failure, indicating to him that the stones, given their size and location, would almost certainly require a surgical procedure for removal. Plus, because the radiologist had no interest in doing operations, getting the word that it was necessary from him represented a much more independent assessment of my condition, compared to the advice I would have gotten from a surgeon. This meeting between a patient and a radiologist was an anomaly, but it may be an important indicator of the future. The past 50 years have introduced important changes to radiology. As the medium moved from analog to digital, it became much easier to store and find films. The images are of much greater resolution, and the speed of digital acquisition of the picture means there's no need to wait for an X-ray film to be developed. It's funny to think back to the clunky old alternator readers, which were machines that had the hard copy films on them, often filed in alphabetical order of the patient studied that day, among which you waited several minutes for the scan of interest to eventually show up. Attending physicians, along with their trainees on hospital teams, would go to the basement each day to review patient studies directly with the radiologist. But now, with picture archiving and communication systems, PACS, those visits are rare. The referral doctor looks at the report and, ideally, although often not, the scan itself, remotely. My friend Saurabh Jha, a radiologist at the University of Pennsylvania, summed up the change well. The radiologist with a flat plate on the alternator was once the center of the universe. With PACS and advanced imaging, the radiologist is now one of Jupiter's moons, innominate and abundant. The whole process, extending from plain films to CT, PET, nuclear, and MRI scans, has been made more efficient, except the interpretation. The classic medical image is the chest X-ray. 2 billion are done each year worldwide. They're often tricky to read, especially when used to diagnose pneumonia. Heart failure and many other overlapping features, such as scarring, a mass or nodule, fluid, or collapsed lung tissue, can confound the diagnosis. Surely a machine that could accurately and quickly read chest X-rays would be a major step forward for the field. As Gideon Lewis Krauss described it, a network built to recognize a cat can be turned around and trained on CT scans, and on infinitely more examples than even the best doctor could ever review. Ingesting tons of images is only a small part of the story, of course. The machine needs to learn to interpret them. Despite that looming issue, Geoffrey Hinton proclaimed, "I think that if you work as a radiologist, you are like Wile E. Coyote in the cartoon. You're already over the edge of the cliff, but you haven't yet looked down. There's no ground underneath. People should stop training radiologists now. It's just completely obvious that in 5 years, deep learning is going to do better than radiologists." Late in 2017, the Stanford Computer Science Group, led by Andrew Ng, claimed that it had. Ng tweeted, "Should radiologists be worried about their jobs? Breaking news. We can now diagnose pneumonia from chest X-rays better than radiologists." Using a convolutional neural network with 121 layers, learning from more than 112,000 films imaged from over 30,000 patients, the team concluded its algorithm exceeds average radiologist performance on pneumonia detection. But, notably, the comparison was for only 4 radiologists, and there were serious methodologic issues. Lior Pachter, a computational biologist at Caltech, wrote, "When high-profile machine learning people oversell their results to the public, it leaves everyone else worse off. And how can the public trust scientists if, time and time again, they are presented with hype instead of science?" We surely can't conclude from the data so far that radiologists are an endangered species, as Hinton and Ng, 2 of the AI world's leaders, suggest. Such assertions have unfortunately characterized many reports on AI in medicine, even though each has the problem of being a retrospective, in silico, non-replicated study, no less with flaws in interpretation of data at many levels. As Declan O'Regan, a radiologist who works on machine learning, wrote to me on Twitter, any PhD can train a deep learning network to classify images with apparent human-level performance on cross-validation. Take it into the real world, and they will all underperform. A radiologist reads about 20,000 studies a year, which equates to somewhere between 50 to 100 per day, a number that has been steadily increasing. While X-rays are single-digit images per exam, ultrasound are dozens, and CT and MRI are hundreds, a ratio that keeps increasing. All told, there are more than 800 million medical scans a year in the United States, which amounts to about 60 billion images, or one image generated every 2 seconds. Nevertheless, radiologists, through training and experience, develop pattern recognition visual systems that allow them to rapidly identify abnormalities. An attention researcher at Harvard, Dr. Trafton Drew, said, "If you watch radiologists do what they do, you're absolutely convinced that they are like superhuman. It's like System 1 thinking because it's reflexive, pattern matching rather than logical analysis. But radiologists still suffer from intentional blindness. That is, they can become so focused on looking for specific things that they will miss unexpected data that is literally in front of their noses. This was demonstrated by superimposing a picture of a man in a gorilla suit shaking his fist into images that a bunch of radiologists were reviewing for signs of cancer. It turns out that 83% of the radiologists missed the man in the gorilla suit. Some studies suggest that errors in interpretation of medical scans are far worse than generally accepted, with false positive rates of 2% and false negative rates over 25%. Given those 800 million annual scans, that means a large number of readings are at risk of being wrong. Notably, 31% of American radiologists have experienced a malpractice claim, most of which were related to misdiagnoses. Radiologists, then, would certainly benefit from a machine accuracy booster. For example, a careful study of classifying more than 50,000 chest X-rays as simply either normal or abnormal achieved algorithmic accuracy of 95%, which could prove useful for radiologists to triage which ones merit a closer look. It's not just about lapses of human attention or errors. Time, too, is a major factor. Instead of a yearly 20,000 films a radiologist can review, millions to even billions of images could be investigated. For example, when Merge Healthcare, a medical imaging firm, was acquired by IBM in 2015, its algorithms got access to more than 30 billion images. What's more, there's plenty of information on a medical image. In every pixel or voxel, a pixel's 3D equivalent, that may not be seen by the human eye, such as the texture, the degree of dye enhancement, or the intensity of the signal. A whole field, sometimes called radiomics, has developed to investigate the signatures lurking in the scan data. For example, it's led to the development of a metric known as the Hounsfield units of the stone density, which reveals the mineral constituent of the stone, such as calcium oxalate or uric acid, as well as indicating the therapy that would most likely be successful. That's perfect for machine reading. Algorithms enable a deeper quantification of the data in scans, releasing heretofore unrecognized value. Several examples bring this pivotal point home. A Mayo Clinic team showed that the texture of brain MRI images could predict a particular genomic anomaly, specifically 1p19q co-deletion, that's relevant to surviving certain types of brain cancer. Similarly, using deep learning algorithms to read MRI scans of patients with colon cancer could reveal whether a patient has a critical tumor gene mutation, known as KRAS, awareness of which should significantly influence treatment decisions. Machine learning of mammography images from more than 1,000 patients, coupled with biopsy results indicating a high risk of cancer, showed that more than 30% of breast surgeries could be avoided. Applying deep learning to X-ray images of hip fractures can lead to diagnoses as accurate as those derived from the more advanced, and so more expensive, image techniques, including MRI, nuclear bone scans, or CT, which doctors otherwise turn to when analyses of X-rays give uncertain results. Using a convolutional neural network with 172 layers, trained with over 6,000 X-rays, with a total of 1,434,176 parameters, and validated in more than 1,000 patients, the accuracy of the algorithm was shown to be greater than 99%, quite comparable to performance by experienced radiologists. Multiple reports from academic medical centers have shown the power of deep learning to sort through a variety of scans, including CT scans for liver and lung nodules and bone age, adding to the expanding evidence that machines can accomplish accurate diagnostic work. UCSF developed a 3D convolutional neural network for chest CT in more than 1,600 patients, of whom 320 had confirmed lung cancer. The University of Tokyo developed a 6-layer convolutional neural network for CT liver mass classification from 460 patients, with an overall 84% accuracy compared with ground truths. Geisinger Health in Pennsylvania used nearly 40,000 head CT scans to show high accuracy of machine diagnosis of brain hemorrhage. Radboud University in the Netherlands found that a deep neural network trained on more than 1,400 digital mammograms gave similarly accurate readings as those performed by 23 radiologists. And Stanford University's convolutional neural network used more than 14,000 X-rays to learn how to quantify bone age, giving results as good as those from 3 expert radiologists. Computer scientists in South Korea at Seoul National University developed and validated a deep learning algorithm using more than 43,000 chest X-rays, trained to detect cancerous lung nodules. The algorithm was remarkably accurate in 4 retrospective cohorts, AUC 0.92 to 0.96. It compared quite favorably to board-certified radiologists and provided additive value as a second reader for even higher accuracy when the two were combined. Surely you don't need a convolutional neural network to get the picture that algorithmic image processing is making great strides. Academic medical centers are not the only groups pursuing the technology, of course. Deep learning of medical images has been undertaken by many companies, including Enlytic, Merge Healthcare, Zebra Medical Vision, ADOC, Viz.ai, Bay Labs, Arteris, Rad Logic, Deep Radiology, and Imagen. Each of these companies has made progress in specific types of images. Arteris specializes in heart MRI and received the first FDA approval for AI medical imaging in 2017. In 2018, Viz.ai received FDA approval for deep learning of head CT scans for diagnosis of stroke, with immediate text notification of clinicians. Imagen followed soon thereafter, with FDA approval for its machine processing of bone films. For Enlytic, the autodidactic processing of thousands of musculoskeletal scans enabled the company's algorithms not just to make diagnoses of bone fractures at remarkable accuracy, but it was even able to spotlight the sites of microfractures even when the fracture was as small as 0.01% of the X-ray image in question. Zebra Medical Vision validated a convolutional neural network that detects vertebral compression fractures with 93% accuracy, whereas radiologists miss such fractures more than 10% of the time. This same company used deep learning for heart calcium score prediction. All of these radiology AI companies are marching along to commercialize their algorithmic scan reading capabilities. By late 2017, Zebra Medical Vision was deployed in 50 hospitals and had analyzed more than 1 million scans at a speed almost 10,000 times greater than can be achieved by radiologists, at a cost of only $1 per scan. It's clear that deep learning and machines will have an important role in the future of radiology. Some pronouncements could be considered exuberant, however, such as Andrew Ng's suggestion that radiologists might be easier to replace than their executive assistants, or the conclusion of the essay by Katie Chalkley and Ezekiel Emanuel, titled The end of radiology? That radiology may disappear as a thriving specialty in the next 5 to 10 years. The venture capitalist Vinod Khosla has said, "The role of the radiologist will be obsolete in 5 years." I know Vinod well and have discussed this issue with him. He didn't mean radiologists would be obsolete, but that their current role as primary readers of scans would. At the other extreme, Emmanuel, the prominent physician and architect of the Affordable Care Act, in a Wall Street Journal article claimed that machine learning will replace radiologists and pathologists, interpreting billions of digital X-rays, CT and MRI scans, and identifying abnormalities in pathology slides more reliably than humans. Even if it's easy to get carried away by the prospects for algorithmic radiology, there is certainly a looming fear among radiologists that the computer overlords are warming up for some kind of takeover. Phelps Kelly, a fellow in radiology at UCSF, examined the state of the field and said, "The biggest concern is that we could be replaced by machines." Radiology is one of the top-paid medical specialties, with annual compensation of about $400,000. The performance of Zebra Medical Vision's technology, or the claim advanced by Andrew Beam and Isaac Kohane, that computers are capable of reading 260 million scans in just 24 hours for only $1,000, makes clear the economic reasons for replacing radiologists with machines. Already, digitally outsourcing the radiological interpretation of images has become an increasingly popular cost-saving measure for hospitals, with companies like VRAD, Virtual Radiologic, employing more than 500 radiologists. Some 30% of American hospitals use the service. Indeed, such outsourcing has grown exponentially in recent years, and is now the #1 professional service outsourced by hospitals. Hospitals are also training fewer radiologists. The number of radiology residency slots offered in the United States has dropped nearly 10% in the past 5 years, although the number of radiologists in practice has been steadily increasing, reaching just over 40,000 in 2016. Given the trends in radiology, why not simply outsource to a machine? At the moment, it still isn't possible. Gregory Moore, VP of Healthcare at Google, and himself a radiologist, has observed that there literally have to be thousands of algorithms to even come close to replicating what a radiologist can do on a given day. It's not going to be all solved tomorrow. Earlier, I pointed out how difficult it has been to integrate all the clinical data for each patient, even for the machine learning companies and health systems that have both a patient's electronic health records and the scan data. Making matters worse, any person who has received health care from many different providers over a lifetime, which is to say practically every American, defies a capture of his or her comprehensive data set. That provides major challenges to computer-based image analysis. Radiologists can provide a more holistic assessment than machines can. Each scan is supposed to have a reason for it being ordered, such as rule out lung cancer for a chest X-ray. A narrow AI algorithm could prove to be exceptionally accurate for ruling out or pointing toward the diagnosis of lung cancer. But, in contrast, the radiologist not only scours the film for evidence of a lung nodule or lymph node enlargement, but also looks for other abnormalities, such as rib fractures, calcium deposits, heart enlargement, and fluid collections. Machines could ultimately be trained to do this, like researchers at Stanford working with their 400,000 chest X-ray collection. But deep learning of medical images so far has been fairly narrow and specific. But even when that problem is solved, the answer to whether radiology should be given wholly over to machines isn't as simple as the costs we pay in time or money. My experience reviewing my scans with my radiologist shows what the future of radiology could be. Even though I have chided those making wild-eyed predictions about the future of radiology, I do believe that eventually all medical scans will be read by machines. Indeed, as Nick Bryan asserted, I predict that within 10 years no medical imaging study will be reviewed by a radiologist until it has been pre-analyzed by a machine. To make sure that an image isn't only analyzed by a machine, however, radiologists need to change. As Jha and I wrote, to avoid being displaced by computers, radiologists must allow themselves to be displaced by computers. If radiologists adapt and embrace a partnership with machines, they can have a bright future. Michael Recht and Nick Bryan, writing in the Journal of the American College of Radiology, stated it well. We believe that machine learning and AI will enhance both the value and the professional satisfaction of radiologists by allowing us to spend more time performing functions that add value and influence patient care, and less time doing rote tasks that we neither enjoy nor perform as well as machines. Although it might seem ironic, Yann LeCun, the computer scientist who is considered the founding father of convolutional neural networks, actually thinks that humans have a bright future in radiology as well. He thinks the simple cases will be automated, but that this won't reduce demand for radiologists. Instead, it will make their lives more interesting while enabling them to avoid errors that arise due to boredom, inattention, or fatigue. Not only could radiologists have more interesting professional lives, however, they could also play an invaluable role in the future of deep medicine by directly interacting with patients. They could be doing more for their patients, sometimes by doing less. As Mark Coley, a UCSF radiologist, correctly pointed out, we're largely hidden from patients. We're nearly completely invisible, with the exception of my name showing up on a bill, which is a problem. To start with, a very high proportion of scans are unnecessary, or even downright inappropriate. Today, radiologists do not serve the role of gatekeepers. Patients simply report for a scan, and it's performed by a technician. In the future, before an ordered scan is performed, the Renaissance radiologist would review whether it's truly indicated and whether another type of scan might be better, such as an MRI or a CT for a question of a tear in the aorta. The radiologist would determine whether the scan ordered is necessary or of the right type and communicate the rationale to the patient. This would have several benefits for the patient. The economic savings in avoiding wasteful imaging would be complemented by the reduced use of ionizing radiation, which, over the course of a person's lifetime, carries a cumulative risk of inducing cancer. This is where the partnership between radiologists and machines could bear even more fruit, as some encouraging studies have demonstrated the possibility of offsetting the reduced imaging power of lower doses of ionizing radiation by pairing those low-dose images with algorithms that greatly improve the quality of the image. Theoretically, with further refinements, it will be possible to offer what are known as ultra-low-dose CT scans, reducing the radiation by orders of magnitude, and even lowering the cost of the CT machines themselves by eliminating the need for very high-powered components. What an unexpected twist. Machines disrupting machines instead of disrupting humans. Image enhancement algorithms are also being applied to MRIs with the goal of substantially reducing the amount of time it takes to scan a patient. Its inventors project a threefold improvement in efficiency, which would make it very attractive to clinics. But the biggest gains might just go to the patient, who would have to remain motionless while being subjected to loud banging noises in a claustrophobia-inducing tunnel for only 10 minutes instead of 60. And all these benefits would be distinct from those derived from using AI to achieve improved interpretation of scans. Besides gatekeeping, another important responsibility for radiologists would be discussing the results with the patient. That's now being done in some breast imaging centers, but it certainly has not been widely adopted across all types of imaging. The pluses for this are striking. Having some conversation and hearing more about the patient's symptoms or history helps the radiologist's assessment of the scan. It provides an independent point of view, distinct, as I've noted, from that of a surgeon, who is usually inclined to operate. The job of the master explainer is going to be especially vital with machine probabilistic outputs of scan findings. Here's a simple example of what an algorithm would produce. Based on clinical and CT features, the probability that the nodule is lung cancer is 72%. The probability that it is benign is 28%. A typical response from a patient would be, "So, I have cancer." The radiologist could immediately mollify the patient's anxiety and explain that there is a more than 1 in 4 chance it won't turn out to be cancer. The need for a human to integrate and explain medical results will become even more pronounced. Take the dreaded prediction of Alzheimer's disease. A group at McGill University developed and validated a deep learning algorithm in 273 patients who had a brain amyloid scan, APOE4 genotype, and follow-up clinical data. The algorithm had an accuracy of 84% for predicting Alzheimer's within 2 years. Another poignant example is for longevity. A team led by Australian researchers used neural network and analysis of 15,957 CT scans from individuals over the age of 60 to develop and validate a 5-year survival plot, partitioning patients by their risk of death, ranging from groups in which 7% were expected to die to groups in which 87% were expected to die. While today these algorithms are confined to research papers and haven't entered the realm of clinical care, it's just a matter of time until they are at least available for clinical care, even if they're not always applied. Among today's medical specialties, it will be the radiologist who, having a deep understanding of the nuances of such image-based diagnostic algorithms, is best positioned to communicate results to patients and provide guidance for how to respond to them. Nevertheless, although some have asserted that radiologists of the future will be essential data scientists of medicine, I don't think that's necessarily the direction we're headed. Instead, they likely will be connecting far more with patients, acting as real doctors. For radiologists to be able to spend time with patients, serving as gatekeepers or master independent interpreters, their workload, the task of translating pixels into words, has to be decompressed. Already, AI algorithms can perform quantification and segmentation of images, which has eased a workflow burden for radiologists. Eventually, machines will take over the initial reading of an image and produce an initial draft of the scan report, with a radiologist's oversight required to sign off and make it official. Ideally, this will include data mining of the comprehensive medical information for each patient and its integration with the scan interpretation. That would save considerable time for the radiologist, who today often has to sift through the electronic medical record to try to connect the dots of the image with the patient's clinical background. We're likely some years away from that objective being comprehensively and routinely fulfilled. Even before the notion that machines might overtake doctors for reading scans, there were pigeons. A considerable body of data gathered over 5 decades has shown that pigeons can discriminate between complex visual stimuli, including the different emotional expressions of human faces, as well as the paintings of Picasso and Monet. In 2015, Richard Levinson and colleagues tested whether pigeons could be trained to read radiology and pathology images. The team placed 12 pigeons in operant conditioning chambers to learn and then to be tested on the detection of microcalcifications and malignant masses that indicate breast cancer in mammograms and pathology slides at 4, 10, and 20 times level of magnification. Their flock-sourced findings were remarkably accurate. This led the researchers to conclude that one could use pigeons to replace clinicians for relatively mundane tasks. Machines are still more likely to supplement radiologists than birds are. After all, machines don't need food or cages. But as the experiment with birds indicates, Pathologists also face a future in which machines can learn to fill at least some of their roles. Pathologists have varied roles and subspecializations. Some are into laboratory medicine, supervising clinical lab assays, others in forensics or autopsy. The pathologists in question here are those such as surgical or cytopathology pathologists who interpret slides of human tissue to make an unequivocal diagnosis of a disease. The problem? It's not so unequivocal. There are innumerable studies showing striking heterogeneity of the interpretation, whether it's cancer, whether it's malignant, whether there's a transplant rejection, and on, of slides by pathologists. For example, in some forms of breast cancer, the agreement in diagnosis among pathologists can be as low as 48%. Even with their training, length of experience, and subspecialty expertise, board-certified pathologists show a considerable error rate and are prone to overdiagnosis. There are multiple causes. Some of the diagnostic difficulty is related to the sample of tissue. Over the years, the trend has been to avoid surgery by using fine, skinny needle aspirates, inserting a needle into an organ from outside the body. The technique has several advantages. The patient experience is better, and the cost of the procedure is lower because there's no need for an operating room, general anesthesia, or an incision. The problem is that there's often minimal tissue obtained. A suboptimal sample, which may not be representative of the tissue or organ under scrutiny, isn't likely to be improved by machine processing, but many other aspects of diagnosis could be. One is a lack of standardization of techniques. There's also a throughput problem. A pathologist doesn't have an infinite amount of time to examine sets of slides with millions of cells. In the analog days, pathologists had cabinets full of glass slides and had to peer through a microscope to look at each one. Now they look at a computer screen. Digital pathology has helped improve the workflow efficiency and accuracy of pathology slide diagnosis. In particular, the digital technique of whole slide imaging, WSI, enables a physician to view an entire tissue sample on a slide, eliminating the need to have a microscope camera attachment. Pathologists have been slower than expected to adopt WSI and other digital techniques, which in turn has slowed the encroachment of AI into pathology. Nevertheless, it's coming. WSI's most important feature going forward is that it provides the foundation for using neural network image processing in pathology. The Stanford group used WSI to develop a machine learning algorithm to predict survival rates in patients with lung cancer, achieving accuracy better than current pathology practice using tumor grade and stage. Thousands of features were automatically identified from the images, of which 240 proved to be useful across non-small cell, squamous, and adenocarcinoma lung cancers. A number of other studies of deep learning for pathology interpretation have been encouraging, and many have been stimulated by an international competition known as the Chameleon Challenge. In 2016, LaHoe and the group at Stony Brook University used a convolutional neural network, CNN, to classify lung and brain cancer slide images at an accuracy level of 70 to 85%, with an agreement level similar to that of a group of community pathologists. Google used high-resolution gigapixel images at 40 times magnification to detect metastasis with better than 92% accuracy versus a 73% rate for pathologists, while reducing the false negative rate by 25%. Google even gave the pathologists unlimited time to examine the slides. There were unexpected problems, however. The Google algorithm regularly made false positive diagnoses. Similar issues were found in a large breast cancer detection deep learning study, with very few false negatives, but far more false positives than a human would make. A key variable for pathologist accuracy turns out to be the amount of time allotted for reviewing slides. Another Chameleon Consortium report by Babak Bejnordi and colleagues assessed the performance of a series of algorithms against that of 11 pathologists in the detection of cancer spreading to lymph nodes. When there were time limits imposed for the pathologists, less than 1 minute per slide, mimicking routine pathology workflow, the algorithms performed better. With unlimited time, the pathologist matched algorithmic accuracy. As is the case with medical scans, the algorithms investigating pathology slides notice things that can be missed by even expert human eyes, such as microscopic evidence of metastasis. Likewise, deep learning can markedly improve the quality of microscope images, sidestepping the problems of out-of-focus or low-quality slides. And as is the case with medical imaging, algorithms can enhance rather than replace the human pathologist. The Computer Science and AI Laboratory, C-SAIL Group at MIT, developed a 27-layer deep network for diagnosis of cancer metastasis to lymph nodes with 400 whole slide images. The algorithm markedly reduced the pathologist error rate, but interestingly, combining the pathologist and machine reading was clearly the best, with almost no errors. This complementarity of machines and humans, each making different correct and erroneous calls, along with neural networks optimizing quality of the slide images, is noteworthy. Synergy hasn't escaped notice of the multiple companies commercializing deep learning tools for path slide analytics, including 3Scan, Cernostics, Procia, Path AI, Page.ai, and Context Vision. For example, Path AI advertises an error rate with algorithms alone of 2.9%, and by pathologists alone of 3.5%. But the combination drops the error rate to 0.5%. Pathologists don't only interpret slides. They can also examine samples at the molecular level, for example, by identifying the epigenetic methylation patterns on tissue DNA to improve cancer diagnosis. Like digital pathology and WSI, there's an overall lag of incorporating molecular diagnostics into routine pathologic assessment of cancer tissue. A study comparing machine analysis of methylation of brain cancer samples with pathologists' review of slides demonstrated the superiority of accuracy for algorithms when such methylation data was available. In another study of pathology slides by researchers from New York University, the algorithmic accuracy for diagnosing subtypes of lung cancer was quite impressive, AUC equaling 0.97. Half of the slides had been misclassified by pathologists. Further, their neural network was trained to recognize the pattern of 10 common genomic mutations and predicted these from the slides with reasonable accuracy, 0.73 to 0.86, especially for one of the early attempts to do so. This finding is noteworthy because it exemplifies the ability of machine algorithms to see patterns not easily discernible by humans. As the incorporation of molecular diagnostics gets more common, including DNA sequence, RNA sequence, proteomics, and methylation, the advantage and complementarity of AI analytics, ingesting and processing large datasets, may become an especially welcome boon for pathologists. Just as there is often marked disagreement for pathologists interpreting slides, there were differences in perception of the deep learning progress expressed in one of the major pathology journals. One group embraced machines. Computers will increasingly become integrated into the pathology workflow when they can improve accuracy in answering questions that are difficult for pathologists. Programs could conceivably count mitoses or quantitatively grade immunohistochemistry stains more accurately than humans. And they could identify regions of interest in a slide to reduce the time a pathologist spends screening, as is done in cytopathology. We predict that, over time, as computers gain more and more discriminatory abilities, they will reduce the amount of time it takes for a pathologist to render diagnosis, and, in the process, reduced the demand for pathologists as microscopists, potentially enabling pathologists to focus more cognitive resources on higher-level diagnostic and consultative takes. For example, integrating molecular, morphologic, and clinical information to assist in treatment and clinical management decisions for individual patients. In contrast, the essay subtitled Future Frenemies called out the poor diagnostic accuracy of the deep learning algorithms to date, emphasizing the human edge. We believe that a pathologic diagnosis is often a well-thought-out cognitive opinion, benefiting from our training and experience, and subject to our heuristics and biases. But it's more than human cognition. Much like radiologists, pathologists have had no real face to patients. It's their doctor who relays the report, and their doctor often has little appreciation for the nuances involved in the interpretation of a path specimen. Establishing direct patient contact to review the results could be transformative, both for pathologists and for patients and their physicians. The remarkable AI parallels for radiology and pathology led Saurabh Jha and me to write an essay in JAMA about the information specialists. Recognizing that many tasks for both specialties will be handled by AI and the fundamental likeness of these specialists, we proposed a unified discipline. This could be considered a natural fusion that could be achieved by a joint training program and accreditation that emphasizes AI, deep learning, data science, and Bayesian logic rather than pattern recognition. The board-certified information specialist would become an invaluable player on the healthcare team. Tumor boards are a fine example. In modern practice, tumor boards are multi-specialty groups that review each patient's diagnosis of cancer and treatment alternatives. Typically, this board includes a medical oncologist, a surgical oncologist, and a radiation oncologist, covering the gamut of drug, surgical, and radiation treatments available to a patient. But with the increasing prominence of AI in imaging and pathology, the information specialist will be an essential member of the team, the one who really understands the basis for deep learning diagnostic and prognostic algorithms. Of note, the first peer-reviewed research paper by IBM Watson Health was comparing its input with the Molecular Tumor Board at the University of North Carolina Lineberger Comprehensive Cancer Center. Of more than 1,000 cases retrospectively reviewed by the Tumor Board and Watson, more than 30% were augmented by AI information, particularly related to treatment options for specific mutations. Like radiology and pathology, dermatology involves a great deal of pattern recognition. Skin conditions are among the most frequent reasons for seeing a doctor. They account for 15% of all doctor visits. Unlike radiology and pathology, however, about 2/3 of skin conditions are diagnosed by non-dermatologists, who frequently get the diagnosis wrong. Some articles cite error rates as high as 50%. And, of course, dermatologists don't just look at and diagnose skin rashes and lesions. They often treat or excise them. But the pattern recognition of skin problems is a big part of medicine and a chance for artificial intelligence to play a significant role. With relatively few practicing dermatologists in the United States, it's a perfect case for machines to kick in. The digital processing of smartphone selfie skin lesions got off to a rocky start, with a proliferation of mobile apps with variable results. Back in 2013, an evaluation of smartphone apps for melanoma diagnostic accuracy showed that cancerous growths were wrongly classified as benign 30% of the time. Accuracy ranged wildly from 6.8 to 98.1%. Another study assessing 3 apps showed poor sensitivity, 21 to 72%, and highly variable specificity, 27 to 100%, compared with dermatologists. The patterns that a dermatologist might need to recognize are a broad group, including skin rashes and lesions, but correctly identifying skin cancer is regarded as the principal goal for AI in dermatology. This is the case especially for the early detection of melanoma, before it spreads to lymph nodes and throughout the body, as that translates to a far better 5-year survival rate, 99% if detected early versus 14% if detected in late stages. Overall, skin cancer is the most frequent human malignancy, with its highest incidence in Australia and New Zealand, about 50 per 100,000 population, and 30 per 100,000 in the United States. This translates to more than 5.4 million Americans with new cases of skin cancer each year, at a cost of over $8 billion. 1 in 5 Americans will develop skin cancer in their lifetime. But, fortunately, non-melanomas are 20 times more common than melanoma. The critical issue is to distinguish between keratinocyte carcinomas, the most common skin cancer, with a very high cure rate, versus malignant melanoma. Wrongly identifying a growth as melanoma can lead to unnecessary biopsies, especially among non-dermatologists, for innocent, benign lesions. Missing one is worse. Melanoma kills approximately 10,000 Americans each year. The classic way dermatologists diagnose melanoma is using a heuristic, an acronym known as ABCDE, which stands for asymmetry, irregular border, more than one or uneven distribution of color, a large, greater than 6 millimeter diameter, and evidence that the mole is evolving. Dermatologists not only rely on their experience and eye, but use a dermoscope to magnify and light up the lesion of interest. That's very different from photographs of a skin lesion taken at variable distances and angles with different lighting conditions. The looming question in the era of AI was whether this could be simulated or even exceeded with deep learning. In 2017, one of the most impressive deep learning papers yet published appeared in Nature with its Lesions Learnt cover on the diagnosis of skin cancer. The algorithm had 2 goals: accurately classify lesions as benign or malignant, and if malignant, whether it is melanoma. Andre Estiva and colleagues at Stanford University used a Google CNN algorithm, Google Net Inception v3, that was pre-trained with ImageNet's 1.28 million non-medical images of more than 1,000 object classes. The neural network was trained via 129,450 images of skin lesions, representing 2,032 skin diseases. But many of these images were photographs, not biopsies, so definitive validation was performed with biopsy-based diagnosis on 1,942 lesions, resulting in a yes or no classification both of whether the image showed cancer and whether the cancer was malignant, including both photographs and dermoscope images for the latter task. The results were tested against more than 20 board-certified Stanford dermatologists. Each dermatologist, who hadn't seen any of the lesions previously, was asked whether he or she would biopsy the lesion or reassure the patient. The algorithm outperformed each of them for classifying cancer in 135 dermoscopic images and was better than the average dermatologist for 130 photographic images of melanoma and 111 dermoscopic images of melanoma. The Stanford paper's use of a CNN algorithm for assessing skin cancer was replicated by IBM Watson with higher accuracy compared with 8 expert dermatologists for melanoma. A subsequent refinement of the algorithm used by the Stanford study, Google's Inception v4 CNN, was put to the test against a much larger group of 58 dermatologists for the specific diagnosis of melanoma. And again, most humans were outperformed. There are major implications and questions about this research. The accompanying Nature editorialists asked whether medical staff would become mere technicians responding to a machine's diagnostic decisions. Those are precisely the broad implications that this book is meant to address. But the editorial also recognized, critically, that an algorithmic test drive is not the same as using a technology in the real world. To date, very few patients of non-European ancestry have been included in algorithmic training. The CNN has to be clinically validated. That's why it was surprising to see one of the skin lesion studies release its algorithm to the public for mobile device use without such validation. Dermatologists assessed in these studies were not looking at patients and didn't have to worry about making an incorrect diagnosis. In the real world of dermatology, it isn't just a look at a lesion that is telling. The history of the lesion, the individual risk factors, a more extensive assessment of the whole skin of the patient are all in the domain of information the dermatologists acquire during a visit. Furthermore, it's not just a binary call of cancer or not cancer, but the decision to simply monitor the lesion over time before deciding to do a biopsy. Accordingly, we can consider the algorithm as a contrived, narrow way to make a diagnosis and biopsy plan compared to the real clinical world. Nonetheless, it's clear that deep learning can help promote accuracy in detection of skin cancer. What the Stanford study did show, unequivocally, was that it's ready for further testing. Other algorithms are in the works too. Companies like Visual DX, which has teamed up with Apple's machine learning group, are helping to make diagnoses of skin rashes and lesions well beyond cancer from a database of over 30,000 images. These collective efforts could ultimately have implications anywhere in the world, any time, where there is a person with a smartphone, broadband, internet access, and a skin lesion of interest. As I noted, there aren't very many dermatologists in the United States. Fewer than 12,000 dermatologists to look after more than 325 million Americans. So the story here isn't so much replacing dermatologists with machines as empowering the family physicians and general practitioners who are called on to do most of the dermatological grunt work. A fully validated, accurate algorithm would have a striking impact on the diagnosis and treatment of skin conditions. For dermatologists, it would reduce the diagnostic component of their work and shift it more to the excision and treatment of skin lesions. It would make primary care doctors, who are the main screening force for skin problems, more accurate. For patients, who might otherwise be subject to unnecessary biopsies or lesion removals, some procedures could be preempted. From this tour of medical scans, path slides, and skin lesions, we've seen the potential role of AI to change medicine by ameliorating the accuracy of diagnosis and making the process more efficient. This is the sweet spot of AI, reading patterns. But certainly no data have yet emerged about replacing doctors, even in these most vulnerable specialties. Now let's turn to clinicians who aren't looking at such classical patterns in their daily practice.